All right, EMT class, chapter 24, trauma overview. Let's see what's going on. So, introduction. So, for people younger than age 44, traumatic injuries are the leading cause of death in the United States. Most of us should be able to kind of piece this together. You know, many times these are the, hey, hold my beer and watch this moments, as well as just, making many other poor choices. But also, people are just a lot more active at this and out doing a little bit more crazier things than, say, the older population is doing. So you can see traumatic emergencies occurs as the result of physical forces that are applied to the body. Now, medical occur from an illness or condition not caused by an outside force. That's going to be the difference between traumatic and medical emergencies. So traumatic injuries may be caused by underlying medical conditions or medical illnesses that may result from traumatic injuries. So thinking about, you could have something going on that then caused you to become injured in a traumatic way. So, So evaluation of the mechanism of injury. For the trauma patient, that's going to help provide us with an index of suspicion for different types of serious and or life-threatening underlying injury. So now you might ask what that index of suspicion is, and that's kind of just that awareness or concern for potentially serious underlying and unseen injuries. So many times it's going to be kind of just that gut feeling that you have, or maybe it's based upon the history of you running many of these kind of calls that you typically see this wrong as well. But you just kind of get that gut feeling or that suspicious feeling that something else is going on. Now, energy, that's what a lot of this has to do with, is energy. Energy causes a lot of injury. When we start talking about car crashes and bullet wounds and all of these things, energy is at the core of it. So traumatic injuries occur when the body's tissues are exposed to energy levels beyond their tolerance. So, when you get into a car crash, there's more energy than what, say, your skin or your femur bone or whatever it is can handle. So that mechanism of injury, that's the way the traumatic injury occurs. So when we ask about what the mechanism of injury is, we're asking, how did this occur? What is the way that this traumatic injury occurred? And what it does is it kind of describes the forces, or if we want to take it back to energy, kind of that energy transmission acting on the body that causes the injury. That's going to be what we're talking about. So three concepts of energy are typically associated with injury. You have potential energy, kinetic energy, and then energy of work. Now, as you probably remember back from high school or any science class you've taken, energy can't be created nor destroyed. All that can happen is it can be converted or transformed. So that's why just the end of the car crash, there's still more stuff going on, because that energy did not just stop. It just got converted or transformed into another subject. So work, when we start talking about work, it's defined as the force acting over distance. Forces that bend, pull, compress tissues beyond their inherent limits result in the work that causes injury, and that's what we're talking about. So kinetic energy is the energy of a moving object. What that does, it reflects the relationship between the mass or the weight of the object and then the velocity or the speed at which it is traveling. So kinetic energy equals half of mass times velocity squared. According to the equation for kinetic energy, the energy that is available to cause injury doubles when an object's weight doubles, but quadruples when its speed doubles. So speed or velocity is going to obviously be the most important thing here. That's why a high-speed bullet, meaning a rifle, is going to do a whole lot more damage than clearly a BB gun or a smaller pistol, or really just nearly any pistol. So potential energy, we mentioned it as the product of mass or the weight, force of gravity, and the height. Now, this is mostly associated with the energy of falling objects when we talk about that. So the MOI, mechanism of injury profile. So different types of mechanism of injury. They're going to produce lots and lots of different types of injuries, as you can imagine. So non-significant MOIs Injury to an isolated body part is more what we're thinking. A fall without an LOC or a loss of consciousness, those are going to be more of the non-significant. You know, when someone is walking and they trip and they fall down and go boom, but they didn't get knocked out. That's going to kind of be our difference between non-significant and significant. Significant injuries, injury to more than one body system. So they took a shot to the noggin, and then they had something go through their arm. You know, they were in a bad car crash, and they have multiple systems at work here. They also had a fall from height. So when you talk about someone ground level fall that are just walking versus falling from the top of a building, you're going to see a lot of differences. Motor vehicle, motorcycle crashes, we're still talking about significant MOIs. Car versus pedestrian, or even a bicycle or motorcycle. You know, car versus pedestrian, not going to be, more times than not going to be a very good outcome there. Gunshot wounds, stabbings, these are all significant MOIs. Now, within that trauma category, we have several different categories, or I guess subcategories. So blunt trauma, penetrating trauma. Traumatic injuries can be divided into two separate categories, blunt and penetrating trauma, and that's what we're going to talk about. So blunt trauma is going to be the result of force to the body that causes injury without penetrating the soft tissue or internal organs and cavities. So think more like someone getting, we'll kind of talk about the same thing, same injury, but two different ways. So someone got hit on their arm with a baseball bat, okay? That caused injury without penetrating the soft tissue or the internal organs and cavities. But then you have a penetrating trauma, which now we're talking about they got shot in the arm, in the same arm that they got hit with a baseball bat, but now we have a penetration. So penetrating trauma causes injury by objects that primarily pierce and penetrate the surface of the body. It also causes damage to soft tissues, internal organs, body cavities, all of that. So now you can get either type of these type of injuries from a variety of MOIs, variety of mechanism of injury. It's important to consider unseen as well as visible obvious injuries with either type of trauma. So if somebody got hit by a car and they don't have any penetrating trauma, what appears to your eyes doesn't mean there's nothing going on inside. So that's kind of where we might get that index of suspicion. By knowing the A&P, by knowing the anatomy and physiology and understanding how the body works, we can see that, oh, this could cause a problem. I'm not seeing a problem, but there could be an underlying problem. Blunt trauma results from an object making contact with the body. So motor vehicle crashes, falls, those are some of the more common MOIs. One of the things we want to think about is we need to be alert to skin discoloration and pain also. These could be the only signs of blunt trauma that we might see. So with some of these kind of things, we might have a high index of suspicion for hidden injuries, that they might have, you know, some internal injuries, even though we're not seeing them externally. Now, lots of different vehicular crashes. You see, we have them all listed here. So they're classified as frontal or head-on, rear end, lateral or T-bone, rollovers, and rotational, meaning it's like a spinning one. Principal difference is going to be the direction of the force of impact for these. Crash consists of 3 collisions. So car against a tree or object, and we start talking about the 3 different ones. Saying the damage to the car does not directly affect patient care, but it does provide information about the severity of the collision. So we see that, you know, this head-on into a pole, probably traveling at a high rate of speed. We can understand there could be some real injuries inside this vehicle. So by assessing the vehicle, we can often determine a mechanism of injury because we know that they're going to fly forward in a very fast fashion. Passenger against the interior of the car, kinetic energy produced by the passenger's mass and velocity, that's going to be converted into work or stopping of his or her body. So like within these kind of injuries, we might see some lower extremity fractures, rib fractures, head trauma. You have a passenger's internal organs against the solid structures of the body. So, you know, these internal injuries, they may not be as obvious as external, but often these guys are the most life-threatening. We see that his brain kind of got knocked around inside his noggin, And that's going to be a bad thing. We know that it's a closed compartment and there's not much room for expansion or bleeding or swelling or anything. So, with this kind of patient, we might want to pay attention to head injury type symptoms, right? Altered LOC, unresponsiveness, maybe a change in some vitals, those type of things. Now, significant MOIs include the following findings. So, death of an occupant in a vehicle. And what we're saying is if we see this with a car crash, we need to be thoughtful about the patient, regardless of whether they're sick or not. But if they have a death of an occupant in the vehicle, we know that with that death, there was a lot of energy transferred. Maybe it all went into them, but there was enough energy within the compartment of that vehicle that it did kill somebody. If there's severe deformity of vehicle or intrusion into the vehicle, so meaning the outside goes into the inside, that's what we're talking about, intrusion. So what we could be talking about is the dashboard being pushed back. Maybe it got pushed back 8 inches. Well, all that tells us is the amount of energy that was involved in this car crash. Severe damage from the rear, crashes in which rotation is involved, ejection from the vehicle is going to be a very significant. Now, frontal crashes. Evaluate supplemental restraint system. So we want to make sure that that they had it on and it was working and all of that. So determine whether the passenger was restrained by a full and properly applied 3-point restraint. And then we also want to look at the airbags. Now that's something you're going to want to communicate in your documentation, as well as to either the ER crew or maybe an ALS crew. You're a BLS crew, so maybe an ALS crew that's coming up. You want to let them know that's a restrained driver with no airbag deployment, or whatever the situation was. So seat belts and airbags, they're most effective in preventing a second collision inside the motor vehicle. We talked about multiple collisions. So now we're talking about the car getting hit, but not the patient hitting the car from the inside, that second component of the crash. Seatbelts may decrease the severity of the third collision, and then airbags decrease the severity of deceleration injuries and decrease injury to the chest, face, and head. Now, despite these airbags, we do want to still be suspectful of some injuries. So extremities resulting from the second collision, make sure that we don't have, they got hit by something in the vehicle or their extremities hit the vehicle as well. And then, of course, internal organs resulting from the third collision. So, the brain knocking around or something from the inside knocking into itself, essentially. Now, children shorter than 4'9" should ride in the rear seat. So in a pickup truck or a single-seated vehicle, these airbags should and hopefully will be turned off because they can cause a real problem for these little ones. So remember that if the airbag did not inflate during the accident, it could deploy during extrication. Now would be a good time to insert a video that I've seen before, but I wouldn't even know how to get it when I was going through some classes, that someone was taking care of the person in the passenger seat and the airbag went off while he was in there with that patient. So you want to make sure that if the airbag is not deployed, that people are, you're getting them out of there and sitting them on the cot and you can work on them there. If you don't have an optive choice, you may not have a choice, but it's just one thing typically is better than another. Here we can see some seatbelt marks. So remember what supplemental restraint systems can cause harm, whether they are used properly or improperly. If someone doesn't have this part right here, on their shoulder and only go around here, well, that can cause harm. It's not meant to be worn like that. And as you see here, even the ones that are worn properly can still cause a lot of harm. But what you should be kind of suspecting is that how much more damage would be if they weren't wearing that. So there's still that same amount of energy that we've talked about, but internal injuries can occur when the belt is worn too high. If it's worn too low, you could see some hip dislocations. And then lumbar spine fractures are also possible, particularly in children and older patients as well. Now you want to look for contact points. So for passengers riding in vehicles equipped with airbags but not wearing seat belts, they're often thrown forward and they come in contact with the airbag and or the doors at the time of deployment. So that's what we're talking about as a contact point. We want to look for contact points between the patient and the vehicle as you do a little quick, little sweep of a little evaluation of the interior of the vehicle and look to see if there's anything that could have cause some problems. Now, rear end crashes. This guy was hit from behind. What we'd expect probably is going to be some whiplash type injuries. If they don't have a headrest, if it's not appropriately placed or fitted type headrest, then we could really expect that they're going to have some whiplash type injuries. So as the body's propelled forward, the head and neck are left behind. So what can happen here is you can certainly get some cervical spine damage or injuries. Acceleration type injury to the brain is possible, and there's that third collision of the brain with the skull. Lateral crashes, so side impact, very common cause of death associated with motor vehicle crashes. Those T-bone crashes cause a lot of damage, and it's a whole lot of energy into a kind of a pretty specific spot of the vehicle. So the vehicle struck from the side is usually struck above its center of gravity, and that begins to rock away from the side of the impact, and then that results in the passenger sustaining a lateral whiplash injury. So that energy, once again, is going through the compartment into the passenger, and they have a very good chance of sustaining a lateral whiplash injury. Now, if there's substantial intrusion, remember we talked about kind of the outside going into the inside. Now, when I say that, I don't necessarily mean the bumper. Now, if the bumper is in the patient compartment, you're really in trouble. But what I'm talking about is all of those, whatever it is, dashboard, the rear dashboard thing, whatever, the side components of the door, when everything's pushed into the other space where it doesn't belong, that's what we're talking about as intrusion. So if there's substantial intrusion into the passenger compartment, we need to suspect a few things. So lateral chest and abdomen injuries on the side of the impact. We understand that chest and abdomen injuries can be a big deal. Possible fractures of the lower extremities and pelvis, ribs, all of that. And then even some organ damage. So organ damage from the third collision. Now, approximately 25% of all severe injuries to the aorta that occur in motor vehicle crashes are a result of lateral collisions, because things just get sheared off, and it becomes a real problem because there's so much force being applied on there. Now, rollover crashes. So large trucks, sport utility vehicles, because of their center of gravity, they have a higher center of gravity. They are all going to be prone to rollover type injuries because of that high center of gravity. So really, the injuries depend on whether the passenger was restrained in these types. So if the person was restrained or not. Most unpredictable type of injuries are caused by rollovers, in which a passenger is unrestrained. It's very easy for someone to get launched out the window or ejected, or I don't know if necessarily worse or not worse, but we'll just say worse, a partial ejection where the vehicle rolls, they go partially out the window and the vehicle continues to roll. Now, even when restrained, as you can imagine, these patients, they can sustain severe injuries in these rollover crashes. Rotational, let me make sure I didn't miss one because my button was messing up. Yeah, we're good. Rotational crashes. So spins are conceptually similar to rollovers because of things spinning around and weight being shifted so drastically. These spins, they are conceptually similar to a rollover, but the rotation of the vehicle as it spins, what happens is it provides opportunities for the vehicle to strike objects, such as utility poles. It doesn't just get hit and stop, much like that rollover. It continues to move, and by doing that, it has that opportunity to strike some stuff. Now, car versus pedestrian. From what I've mostly seen in my time on the street, this is either nothing or it's really bad. I haven't seen too many that were kind of middle of the road, like, he's kind of banged up. It's usually they're just, you just don't even understand how they're not hurt or they are really hurt. As you imagine, when we start talking about energy being transferred, a car's energy going into a person standing in the street corner, or maybe they're playing in their yard and a car goes off the street or whatever, not going to be very good. So as you can imagine, these are going to be often graphic, and the injuries are going to be apparent. So there can also be some serious unseen injuries, as you can imagine, to underlying body systems, because like I said, all of that energy has to go somewhere. So we do need to maintain a high index of suspicion for some of these unseen injuries that we've kind of talked about. So some of the things we want to talk, that we want to make sure we know, you should determine, we want to talk about the speed of the vehicle, whether the patient was thrown through the air and at what distance. Of course, what surface did they land on? Maybe they landed on into a field, you know, onto some grass, or did they land into hard concrete? Because one can continue the damage, whereas the other one absorbs some things. Excuse me, and then whether the patient was struck and pulled under the vehicle. So you evaluate the vehicle that struck the patient for structural damage. What we're doing is we're looking to see how much damage the front end of that vehicle has, because that kind of tells us even the more damage we see on that vehicle, the more damage we can expect with our patient. If you are on a BLS truck and you have this call, you should probably be calling for ALS backup as soon as you can. ALS backup probably should be summoned for any patients who have or are thought to have sustained a significant MOI. So if basically, if you just get a dispatch report of how sick they are, or you roll up and it's not the one that I'm telling you about, they're just walking around and talking, and you don't have an index of suspicion, like the vehicle doesn't have hardly any damage or any damage at all, they seem to be fine. Anything really less than or greater than that, I would be calling for ALS backup. Car versus bicycle. The more city, the more urban type environment you work in, the more type stuff you'll see like this. These little guys and girls, they're not that good at looking down the street as they ride out between two vehicles. And you know, our first thought is that the driver should have been paying better attention, but if you've ever been in that moment, these little guys can just jet right out in front of people. So, you know, this happens more, the busier the area that you work in, the more you'll see stuff like this. So what you want to do, you want to evaluate their MOI, mechanism of injury, in much the same manner as car versus ped crashes, car versus pedestrian. So you might hear it called an auto ped. So automotive versus pedestrian. So if you hear me referring to it as that, then that's what we're talking about. So just like in that situation, you want to evaluate the damage and the position for the bicycle. Maybe the bicycle took a lot of the energy, you know, we don't know. We also want to know whether the patient was wearing a helmet, and then inspect it for damage as well. Now we do, basically, if you think about it, we want to err on the side of these patients, right? So we're going to presume the patient has sustained an injury to the spinal column or spinal cord until proven otherwise. And how do we do that on an ambulance? You're right, we can't. It needs to be looked at with x-ray and everything. So we're going to go ahead and board them up. You know, we're going to explain to them, even if doesn't seem to be something wrong, if they're not complaining of that, but you know, they have other injuries, we're going to explain it's just prevention. It's just to prevent any further damage, and just, you know, it's not a big deal if they don't want to, but we really need to get them onto a board and maintain stabilization. C-spine. So spinal stabilization must be initiated and maintained during the encounter. So from the time you walk up there until the time you drop them off, you need to either maintain C-spine with your hands or with a device. But we do need to do our best at maintaining that. Car versus motorcycle. So their protection of motorcycle, for the most part, is going to be a helmet, which doesn't protect against cervical injury, as you can imagine. Leather or abrasion resistant clothing, and that's just going to mostly protect against road abrasion, but you know, it's not going to protect against blunt trauma. And then boots, not a lot of protection here. So these collisions usually occur against larger vehicles or even maybe a stationary object. So when we assess these scenes and we roll up and we look at these scenes, some of the things we're looking for: deformity of the motorcycle, side of the most damaged, distance in the skid, and then deformity of stationary objects or other vehicles. Also, we want to think about extent and location of deformity in the helmet. That lets us know how things were struck. So 4 types of motorcycle impacts: a head-on crash, where the motorcycle strikes another object and stops its forward motion while the rider continues his or her forward motion until stopped by an outside force. So that's a head-on crash. Angular crash. Motorcycle strikes an object or another vehicle at an angle, so the rider sustains direct crushing injuries to the lower extremity between the object and the motorcycle. So they're kind of similar to a head-on crash, except they're at an angle to where you're still doing a lot of damage, not just necessarily a glancing blow. Ejection, so the rider will be traveling at a high speed until stopped by a stationary object, another vehicle, or road drag. So as you can imagine with this, severe, you're going to see probably some bad road rash, and sometimes you may even see it where the road rash is all the way down to the bone if they were kind of drug around a little bit. And then controlled crash. So a technique used to separate the rider from the body of the motorcycle and the object to be hit. It's referred to as laying the bike down. So it's a little bit more of a kind of a controlled chaos because they can control how this thing goes to an extent. Now moving on to falls. So injury potential of a fall going to be related to a couple of things. So related to the height from which the patient fell, also related to the patient themselves as to whether how healthy they are, and they have good solid bones and all of that. But the greater the height of the fall, the greater for potential of injury. So a fall for more than 20 feet, that's going to be considered significant when we talked about significant and non-significant things. So internal injuries pose the greatest threat to life for these. Patients who fall and land on their feet, they may have less severe internal injuries because their legs can actually work as a shock absorber and absorb much of the energy of that fall. However, they may have some serious injury to the lower extremities, even the pelvis and spinal injuries, because once again, all of that energy goes somewhere, right? So you see on this, you can certainly get, I forgot what it's called, but the fracture of the calcaneus. And you can see it going into the spine, and the femurs and hips as well. So take the following factors into the account: the height of the fall, the type of surface struck. So once again, was it soft and cushiony, or was it hard concrete? And then part of the body that hit first, and then followed by the path of energy displacement. So where did the energy go? Now, hopefully we come up and we see this and we go, okay, that's sick. So penetrating trauma. Been talking about some blunt trauma, talking about, car crashes and all of that. Now we'll talk about penetrating trauma. So the second leading cause of trauma death after blunt trauma is penetrating trauma. Low energy penetrating trauma can be caused by accidental. It's an accidental impalement. It can be intentional, by knife and ice pick and many, many other things. Many times it's difficult to determine the entrance and exit wounds from projectiles in a pre-hospital setting. It's so messy and there's so much adrenaline and all of that. May or may not be able to tell about entrance and exit wounds. So you do want to do your best to determine the number of penetrating injuries and then combine that information with the important things that you already know about the pathway of penetrating projectiles. So where that thing could be going. Maybe it's headed for the liver. Maybe it's headed for the spleen. Now, with low energy penetrations, injuries are caused by the sharp edges of the object moving through the body. Now, therefore, close to the object's path. So things that are close to the object's path is what we're concerned about. Knives may have been deliberately moved around internally, causing more damage than the external wound suggests. So sometimes when people will stick one of these in somebody, there may be some movement trying to get to other organs and stuff. There's a lot of fairly violent people out there. So we know that there could be a lot more damage than what we see. So one of the things you want to try to do is determine the length of the penetrating object. So if it's got is it just a little pocket knife that has a 2-inch blade, or maybe it's got a 6 or an 8-inch blade, or if we're able to kind of determine that, it'll help. Now the path of the projectile, it may not be very easy to predict because there's lots of things that can go wrong. So when we talk about a bullet, the bullet can flatten out and tumble. It can even ricochet within the body before exiting. So the path the projectile takes is its trajectory. Then fragmentation will increase damage. If talking about a bullet, if a bullet starts breaking off and becomes fragmented, it's going to increase damage as well. And then still talking about a bullet, the bullet speed is another factor in the resulting injury pattern. So it could just be going straight through, or it's starting to slow down. Now, cavitation. So cavitation results from the rapid changes in tissue and fluid pressure that occur with the passage of the projectile. So this can result in serious injury to the internal organs distant to the actual path of the bullet. Now, temporary cavitation injury results from the stretching of the tissues that occurs with the pressure changes, and then you also have permanent cavitation. That results closer to the bullet path and remains after a projectile has passed through the tissue. So it's making this big cavity as whatever it is passing through, and what happens is it kind of gets blown out, and then what finally settles down, that becomes kind of the permanent cavity, which was where that thing actually passed through. Penetrating trauma. Relationship between distance and severity of the injury varies depending on the type of weapon involved. So got a lot of different types of weapons that we've talked about, and we know there's a lot more kinds out there. Air resistance, often referred to as drag, that slows the projectile. So the greater someone's taking a shot from, or whatever, it will slow the projectile, decreasing the depth of penetration and the energy of the projectile. And what hopefully that does is it reduces the damage to the tissues. So the area that's damaged by medium and high velocity projectiles, that's typically many times larger than the diameter of the projectile itself because of that cavitation. This is one result that exit wounds are often many times larger than entrance wounds. So the energy available for a bullet to cause damage is more of a function of its speed than of its mass. Remember, we talked about that speed is going to be a very important variable here. Any information regarding the type of weapon that was used should be relayed to the medical control. And then here's your a whole listing of mechanism of injury, signs and symptoms, and index of thoughts that you might have. So blunt or penetrating trauma to the neck. You might see noisy or labored breathing and increased respiratory rate. And that should make you be aware of some airway possibility of airway compromise, or maybe blood in the airway, so some airway obstruction. You see all of these things listed. Significant chest wall blunt trauma, significant chest pain, could be cardiac contusion. So it's kind of giving you the mechanism, telling you, what might have happened, what you might see, and what might be going on wrong. This is a very good chart to kind of understand and have in your memory banks, because it can help you out when you start trying to figure some things out on the side of the road. Now, blast injuries, hopefully we're not going to see a lot of those, but we certainly do have the potential. Obviously when we're talking about the majority of them, you're going to see that in a military world a lot more often than you are just here in the streets, but most commonly associated with military conflict. Blast injuries are also seen, though, in civilian practice, in mines, shipyards, chemical plants, and association with terroristic activities. So obviously when you're working at a plant or some of these kinds of things, there's lots and lots of opportunities. There's also opportunities for people that are just screwing around with stuff, and then people that are just kind of bad people that are trying to harm people as well. So you see this, you've got all of these different mechanisms of blast injuries here. So you've got the primary blast, I can't think of what it's called, not phase, I cannot think of the right word, but you got the primary blast area, injuries due to the blast wave itself, and then secondary injuries due to missiles being propelled by the blast force, and then just tertiary injuries, so injuries due to impact with another object, and then I believe you pronounce it quaternary blast injuries, so collateral injuries such as burns, crushes, things that happen because of the blast itself. Primary blast injury, so due entirely to the blast itself. That damage is going to be done by the pressure wave, and that was generated by this explosion. Then secondary blast injury, so damage to the body results from being struck by flying debris, the stuff flowing through there from the blast. This is going to be very similar. We'll probably see this more often. These same type of injuries is maybe in a tornado here in Oklahoma. Tertiary blast injury, so the victim is hurled into the force of the explosion against a stationary object. And then, as I said, I believe it's quaternary, burns from hot gases. You can get respiratory injuries, crush injuries, suffocation, all kinds of things. But most patients who survive an explosion are going to have some kind of combination of the four types of injuries that were just mentioned. Organs contain air. They are going to be more susceptible to pressure changes. We're talking about the tissues at risk here. So middle ear, lung, GI tract, these are all going to be things that are more susceptible to pressure changes. Now, junctions between the tissues of different densities and exposed areas, so head, neck, those tissues are prone to injury as well. And then the ear is going to be the most sensitive to blast injury. So the tympanic membrane evolved to detect minor changes in pressure, and it'll rupture between 5 to 7 pounds per square inch above atmospheric pressure. So in these situations, it's not uncommon that someone has a burst eardrum. Pulmonary blast injuries, these things are defined as pulmonary trauma that results from short-range exposure to the detonation of explosions or explosives. Primary blast injury is often characterized by a lack of external visible injuries. We're not going to see these kinds of things. So a pneumothorax in this situation, it's going to be pretty common injury, and it may require an emergency decompression in the field. So we're talking about paramedic level skills. So once again, ALS service, recognizing that we've got sick people and getting the right people there, or getting them to the right place. Now, one thing that can also happen, we've talked about pulmonary edema. This pulmonary edema can also ensue very rapidly after these type of blasts. So one of the most concerning pulmonary blast injury, that's going to be an arterial air embolism. So what happens is it occurs on alveolar disruption with subsequent air embolization. So the alveoli get all jacked up, and you get some air emboli and into the pulmonary vasculature, which we know we're hoping for blood carrying oxygen, not just a big old air pocket that goes through there. So these things can produce several things: disturbances in vision, changes in behavior, changes in state of consciousness, or their LOC, and then a whole variety of other neurologic signs. Now, when we talk about the organ systems, the solid organs, they're relatively protected from this because they're not hollow organs, air-filled organs, they're solid. They could, however, be injured by secondary missiles or anything hurled by the body. When I say missiles, I don't necessarily think, we're not just talking about missiles, we're just talking about some kind of projectile that's moving through the body or through the air. Neurologic injuries and head trauma, those are going to be the most common causes of death from these blast injuries. So we see a couple of different head injuries that are common here: subarachnoid and subdural hematomas. They're seen more often with these type of injuries. With that, we could start to see some bradycardia and hypotension. That's going to be common in these type of patients. There are some responses that happen within the body when you start building up that increased ICP, that intracranial pressure, that cause some bradycardia, also could cause some hypotension, could be hypertensive, but bradycardia is going to be pretty common. Extremity injuries, including traumatic amputations, not that uncommon in these kinds of things. Now, moving on to multisystem trauma. So more than one body system is involved here, and you see them listed: head and spinal trauma, chest and abdominal trauma, chest and multiple extremity trauma. So we're thinking about something big, right? We're talking about a big car crash or a big event. Lots and lots of energy, as we've talked about. So alert medical control, transport these guys fast. Get ALS there, get as many trucks there as you need it, if you need a helicopter or whatever, but you have a big event, then with lots of multi-system trauma, we're going to need a lot of people. Now, golden principles of pre-hospital trauma care. So we want to think about some things. So our main priority, nothing has really changed here, right? Safety. Safety first. So your safety, safety of the crew, safety of the patient. That's still our main priority. Determine the need for additional personnel or equipment, and then we want to look at the MOI, mechanism of injury. Identify and manage life threats. Everything's still going on the same. Then we focus on patient care. So we want to make sure that the airway is good. We want to manage it as we might need to. We want to ensure the basic shock therapy is being completed, so keeping people warm and getting O2 on them. We want to consider bleeding, see if there's any gross bleeding and take care of that. We may or may not need to use a tourniquet in these situations. Protect the spine, proceed with spinal immobilization if indicated, and then we want to make sure that we're transferring people properly to the right place. So what you need to remember is these patients don't necessarily need us. So don't mess around on scene. This is a thing with paramedics as well. There's not much that we can do in the field to help one of these people. Everything we can do in the field, they should be able to do on the way to the hospital. What they need is to get to a surgical suite. What they need is to get to somewhere that can fix all of their problems, and that's not us. So let's not mess around with long on-scene times. These on-scene times should be limited to 10 minutes or less, hopefully less. The less it is, the better. Do everything one time and get it done right, and then move on and get them to the right place. If you're able to, normally we get a sample history and get everything that we're able to get. Now, patient assessment. So we know we've got scene size up, primary assessment, history, secondary, reassessment, right? So we've got our kind of some mnemonics that we've talked about in lab, and 5-3, ABC Go. We've got all of these things. So we need to use these tools that we're learning. When you're caring for a patient who's experienced a significant MOI and the patient's considered to be in serious or critical condition, we should perform rapidly a physical exam. It needs to be done rapid and done quick and get moving. So with a patient who has experienced a non-significant, we can focus on the chief complaint a little bit. We can assess the patient as a whole. But when these sick people, we need to not mess around with these physical assessments and get in and get out. So injuries to the head, disability, unseen injury to the brain may occur. Obviously going to be bleeding or swelling inside the skull. If there is, there's going to, I shouldn't say obviously, in the event that there is, then obviously this could certainly be life-threatening. Include frequent neurologic examinations in your assessment. So talking, looking at their pupils, those type of things. We're looking for changes. Remember, we keep redoing these reassessments to see if something has changed. Maybe we missed something in the front or something has changed. Now, some patients will not have obvious signs or symptoms until hours, maybe minutes, but could be hours after the injury has occurred. It may take a while for it to evolve. Now, injuries to the neck and the throat. This obviously is an area of serious, some serious injuries or even up to deadly injuries. So the trachea could be torn. It could start swelling, which shuts down the airway. So airway problems result that could quickly become a serious life threat. So your assessment must include frequent physical examinations, and then we're also looking for DCAP BTLS, talking about the neck and the head and the throat. So we should already have that figured out, DCAP BTLS. Hopefully you do. Deformities, contusions, abrasions, punctures, or even penetrations, injury, penetrating injury, burns, tenderness, laceration, and swelling. If you don't have that put to memory, please do it. I know we've talked about this and on one of our things in lab, I believe that we've even had to throw down on that and write everything down, but you're going to see that again. Make sure you know DCAP BTLS. What that will help you in your, first it'll help you when you're doing your physical exam. You've got that. It's like our OPQRST, right? But when you go and write your paperwork, you can use that. So, negative deformities, negative contusions. You can either write that whole, maybe it's accepted at your work as DCAP BTLS, and you could write no DCAP BTLS noted, or it will give you an idea of all of the things that you need to address as well. When we're talking about this, we also need to look for JVD, or jugular venous distension, and then we want to look for tracheal deviation as well. The trachea could deviate when one side is injured of the lungs, and what it does is neat little compensatory mechanism skill that it has is it will actually shift to the good side to allow more air to come in. Now, you may see some swelling. Swelling may prevent blood flow to the brain and cause injury to the central nervous system. So some of that swelling, no matter where it's at, can cause some problems. Penetrating injury can result in some air in an air embolism. So use occlusive dressings to prevent this. We're still talking about the neck and throat. If you have a penetrating injury to the throat and you have air going in and out, we need to shut that thing down. We need to close that up. Crushing injury to the upper part of the neck can cause some cartilage damage. So you want to think about that, fractures. Now, injuries to the chest. If you didn't know it, the chest contains the heart, lungs, even the large blood vessels. So lots and lots of important things here that we don't want to be injured. Obviously, there's lots of life-threatening injuries that can happen here. So everything, broken ribs, which isn't a big deal, but it will definitely hinder breathing. And if you've got other things going on, but a broken rib can cause a lot of internal damage too. Bruising may occur to the heart, which if that's the case, that can cause an irregular heartbeat, which is not going to be good. So large vessels of the heart may be torn inside the chest, causing massive unseen bleeding, or even air may collect between the lung tissue and the chest wall, and that's known as a pneumothorax, and that pretty much shuts down breathing and decreases cardiac output, which we know is a bad thing. Now, penetration or perforation of the integrity of the chest is called an open chest wound. So if that thing is left untreated, up to and including death is going to happen. Or it can, but let's just say it probably is going to happen. It's imperative that we assess the chest region, do a good assessment. If we have a question about it, clean an area up to see if that's a laceration or something. As you do another assessment, we want to make sure that nothing's changed within the chest. So we can see good chest rise and fall. We don't see any air bubbles. All of these type of things. Still looking for decap BTLS. Looking for chest rise and fall, listening to lung sounds, because things can evolve. As I've told you guys, someone can get a simple pneumo and it can evolve into a tension pneumo. So a simple pneumo being, it doesn't even cause anybody short of breath. It's such a small pneumothorax that it will probably shut itself, it'll fix itself, or it's just going to get, just a little bit bothersome. But it can certainly evolve into a pneumothorax and then completely shut down this patient. So we still want to listen to lung sounds. We still want to assess the chest for equal chest rise and fall. Now, injuries to the abdomen. The abdomen contains vital organs that require a very high amount of blood flow to perform functions necessary for life. So organs of the abdomen and the retroperitoneum, they can be classified into two categories. We talked about them earlier. We can talk about solid organs and we talk about hollow organs. So solid, liver, spleen, pancreas, kidneys. That's what we're talking about when we say solid. And then hollow, you're going to see things like stomach, large and small intestines, urinary bladder. So solid organs, they can tear, lacerate, fracture, which fracture sounds weird, but it's not a weird thing. It's really bad. So when injuries from trauma occur in this region of the body, serious and life-threatening problems can occur. So we want to make sure that we're recognizing these things. These hollow organs, they can rupture and leak some really bad, yucky stuff into the body, and we don't want that. So the patient can actually develop a life-threatening infection secondary to these injuries because of all of those contents that are leaking out into the body. The rupture of large blood vessels can cause serious unseen bleeding that we're not even noticing. We're not even noticing that this is going on because we can't see it. And we're maybe or maybe not. We're doing very good patient assessment. So lots of things can happen if we're not doing a very good job on our assessments. Now, transport decision, scene time. Less is best. So call for ALS and maybe you need a helicopter to avoid delays in treatment and transport. Scene time, we want to make it down to 10 minutes or less, whatever is best for the patient. So survival of critically injured trauma patients is very time dependent. So we want to limit on scene to the minimum amount necessary to correct life-threatening injuries and package the patient. That's pretty much all we want to do. Correct injuries, package the patient, and get moving. So we want to be less than 10 minutes, as we've said multiple times. So the following criteria will help you identify critically injured patient. So they have a dangerous mechanism of injury, a decreased LOC, that should be a big deal, a decreased level of consciousness. And then any threats to the A, B, or C. Those are our big deals, right? So LOC and then A, B, or C. That should be a big deal. Type of transport. So ultimately you get one of two choices. ground EMS units staffed by EMTs and paramedics, and then you get air EMS who are staffed by critical care nurses and paramedics. So depending upon what kind of patient you have and where they need to go, you may need to call for a helicopter versus getting them there on the ground. Association of Air Medical Services, Medevac Foundation, identify the following criteria for appropriate use of emergency air medical services. So extended period of time to access or to get to your patient. Distance of the trauma center is more than 20 to 25 miles. The patient needs ALS care and there's no ALS ground ambulances around. Traffic conditions, multiple trauma patients who will overwhelm resources. EMS systems require bringing a patient to the nearest hospital rather than bypassing facilities to the direct trauma center. This may add delay to receiving definitive care. So if you're out in an area that doesn't want you leaving their district, no matter what you've got, and you've got to take everything to the local hospital, that's not going to be a very good situation for someone that needs to go downtown. Now, we talk about the destination selection we talk about taking the right people to the right place. Well, let's talk about what some of that looks like. So it is important that we're familiar with how these trauma, how it classifies trauma care, right? So these trauma centers is the word I was trying to think of. These trauma centers, how they're classified. So they're classified into levels 1 through 4, with level 1 having the most resources. So level 1 facility, locally we're talking about OU downtown. Level 1 facility generally serves large cities or heavily populated areas. So it provides every aspect of trauma care. And then usually most level 1 facilities are also university-based teaching hospital. The key point is every aspect of trauma care. Level 2, located in less population dense areas, and that's not always the case because in Oklahoma City there's like three, maybe even 4 level 2 trauma centers. So there's a lot of people there, obviously, because that's the same reason there's a level 1. So it's about the level of care that people are getting. So it provides initial definitive care. They're going to do many things that a level 1 hospital does, but not quite as many resources. So if you have someone that is a level 1, you may want to make sure, and you're thinking about going to a level 2 facility, might want to make sure that that is the appropriate place by calling the level 2 facility. Then level 3, what they do is they provide assessment, resuscitation, emergency care, and stabilization, and then they transfer people out. That's a level 3. I believe Shawnee is a level 3. Level 4, which I believe is PREG, typically found in remote outlying areas where no higher level of care is available, provides advanced trauma life support, and then it transfers to a higher level trauma center. So these are the kind of places that you might take somebody to that needs to have something done pretty quick, and then they transfer them out downtown or wherever the appropriate place are. Now, trauma centers are categorized as either adult or pediatric trauma centers, but not necessarily both. Sometimes you can take a little kiddo over to OU, but typically they want you to take a kiddo to children's. So a lot of times, from what I remember, it just depends upon the injury itself. So if you have a child that's badly injured, I would start with kids. I would start with children's. And if they tell you that they're going to need to go to OU, then call OU and let them know that you were referred by children's in, blah, 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 and tell them what's going on. So pediatric trauma center is not going to be nearly as common. And when you do have a pediatric trauma center, make sure that that's where you're going rather than going downtown to OU first. Make sure that you try to take it to a pediatric place. Now you see here, this is a field triage scheme. I'm going to let you guys read through this, but you got step 1, step 2, step 3, step 4, and then when in doubt, transport to a trauma center. And it asks you different questions of how a patient might fall, and will let you know what you need to do. So, as we've talked about, make sure you remain calm, complete an organized assessment. That's part of remaining calm, right? We've talked about building that systematic approach. So whenever we have a very chaotic and unorganized scene, we can still do an organized assessment. So correct life-threatening injuries, do no harm. First things first, do no harm. And then never hesitate to contact ALS backup. So make sure that you're doing a good, organized assessment. Stay calm. Stay calm. It's not your emergency. That's the biggest thing I can tell you is it's not your emergency. Stay calm. And don't get distracted by, things going the wrong direction, or maybe something's supposed to be on the inside and it's on the outside. You've got to just collect yourself, do a good organized assessment. The big point, that number 3 point, correct life-threatening injuries, and just remember the system that we've built in lab over and over and over, and you just do the next thing. So, like in life, we do 2 things: show up and do the next right thing. Well, we showed up, now we're going to do the next right thing. And that's it. That is the overview of trauma, almost 1 full hour. So that was lots of fun. So I'll see you guys soon.